We have a panel of experts who joined together and will be represented by Dr. Ordóñez a little later. But before we formally begin the presentations, I would like to share some instructions with you. For those of you who are participating, we'd like you to select the language you wish to hear the webinar in. It is being interpreted into English, Spanish, and Portuguese, and you're invited to go to the bottom of the screen where there is a globe of the world where you can open up and select the language of your choice. Please keep your microphones off at all times. There will be a session of questions and answers at the end. We ask you to use the Q&A session to ask your questions. And under chats, just tell us where you come from, what your post is, what you're doing, but questions and answers specifically in the Q&A. In the chat, you can do anything else you wish to add. Welcome to all of you, and I'd like to call on Dr. Pedro Ordóñez. Good afternoon, Jenny, for the instructions, and welcome to all of you. This is October 1st, 2021. We are beginning our webinar celebrating the World Heart Day. This webinar, as we said, will be dedicated to the launching of the new WHO guidelines for pharmacologic treatment of hypertension. My name is Pedro Ordóñez from the Pan American Health Organization here in Washington, and it's a pleasure for me to greet you and invite you to share another webinar of hearts with us. I want to tell you that this webinar will be divided into three large blocks. The first one will be to introduce the methodology and the key recommendations of the hypertension guideline. Secondly, we'll be talking about two topics in the guideline where they speak specifically of the COVID pandemic and hypertension and the algorithm approach for hypertension, which is one of the novel things of the guideline. And lastly, in the third section, we will hear the presentation and the support work of the presidents of maybe the most influential societies of this region who are going to be with us. And we'll end the webinar with the policy implications of the new hypertension guidelines. With no further ado, I'd like to begin our webinar. Once again, as I said, it's the World Heart Day, and I don't have to remind you of the importance of this topic. You know this is critical for the region and for the world. And it's then a pleasure for me to bring in the first section of the webinar, where it'll be a pleasure for me to invite Dr. Vilma Irasola, Professor and Director of the Chronic Disease Research Department from the Institute of Clinical and Health Effectiveness from the University of Buenos Aires, and one of our hearts consultants, who's going to talk about the topic of methods for developing the guideline. Vilma Irasola, you have the floor. Good afternoon to all of you, and thank you very much, Pedro, for inviting me to be part of this important webinar. I'd like to share with you today the key methodologies followed in the preparation of the WHO guideline for the pharmacologic treatment of hypertension. Initially, I'd like to mention the team and then the development process of the guideline. The team who worked included a large number of persons who worked actively and in a collaborative manner throughout the developing process of this guideline. The team included a coordinating group from the WHO who led the organization and oversight of all the activities related to the development of the guideline. Another group was in charge of the actual development of the guideline, which included people coming from different disciplines, including primary health care physicians and specialists in different areas like cardiology and nephrology, nursing and pharmacy staff, researchers, academicians, decision makers, and patients' representatives. The members of this group were selected by the coordinating group, bearing in mind not only their field of knowledge and the different roles of health, but also their representativeness from the different regions and genders. The technical group was in charge of systematically reviewing the literature. We had a methodology specialist who guided us at the different stages, and then there was an external review group who evaluated the recommendations considering the global health needs. I can't mention them all today. I don't have that much time in my presentation, but you can check their names in the guidelines where you can find their names and emails. All the people who participated in the development of the guide completed the standard form of the WHO on their interests, and the WHO policy applied ethical principles of independence and impartiality. As for the development of the guideline itself, it was divided into three key stages. The first, where the initial work sessions took place in July of 2019, during which the group in charge of developing the guideline defined the scope of the guideline and the peak questions that would serve as the spinal column in the development of this guideline, defining the target population, the interventions, the comparator, and the final outcomes. To guide in the formulation of questions, we used a conceptual framework that included the impact of the different interventions on on the outcomes and the outputs based on the target population, who are adults with adequate diagnosis of hypertension. The peak questions were asked and were finally selected. First, the pressure threshold to be key in the drug treatment, whether there's a need to have laboratory tests or not to start the treatment, and whether to have the cardiovascular risk classification to begin the drug treatment. Secondly, the monotherapy role, comparison between the different drugs, monotherapy versus the combined treatment, comparison between the different strategies of combined therapies, and the combined therapies with fixed doses of one single pill or the combination of the drugs individually. And to end, the blood pressure goal, the monitoring frequency, the follow-up, and the role of the medical and non-medical staff in the management and follow-up of the hypertensive patient. Once the questions were asked, we began the second stage, during which the technical literature review group reviewed each one of the questions systematically. 159 systematic reviews were included, with 17 primary cares which were published between 2015 and 2020. The technical group also carried out an evaluation of the quality of the evidence based on the Gregg methodology. An additional review of reviews was necessary to compile the evidence, including other aspects to be considered within the framework of the evaluation. And I'll just mention these aspects in a few minutes. Here we see some of the examples which we used for the technical group as an evidence map and summary tables of the evidence and the degree of certainty. And we come to the third stage in February of this year, where the work sessions of the group took place to develop the guidelines formulating the recommendations, which are of two types: the strong recommendations and the conditional recommendations. In these strong recommendations, there was trust in that the beneficial effects of complying with the recommendation exceeded the damages or the undesired effects. And it was felt that these recommendations were the standard of care. In the conditional recommendations, though the beneficial effects of compliance with the recommendation probably exceeded the damages or undesired effects, there was no sufficient trust in the balance. Hence, variability was expected in the application of these recommendations, depending on the circumstances. An important thing was what considerations were used to develop the recommendations. Well, of course, the degree of certainty of the net benefit based on the evidence. But this was not the only aspect that was taken into consideration. We also included the benefits and potential damage balance, the values and preferences of patients and users, the need for resources costs and cost effectiveness. And very importantly, aspects related to acceptability, feasibility in the different contexts, and the equity impact on health. And as a final consideration, I'd like to highlight the fact that in the guidelines, we've followed the methodology, which was rigorous and transparent. The team was multidisciplinary and inclusive, and the guideline is based on the degree of certainty of the evidence and the balance between benefits and damages, but also considers, as I mentioned, values and preferences, resources, acceptability, feasibility, and impact on health equity. And now I'm going to explain some of the recommendations of the guideline from dawn, but I didn't want to end without asking ourselves, what's our next challenge? And without a doubt, our next challenge is the effective implementation of the recommendations in the daily practices of our health services. I think that we all understand that there is a difference between what we know, the evidence, what we have, and what we actually end up doing in the practice. And for this reason, implementation in research seeks to reduce the distance and helps us establish bridges, identifying the best strategies to achieve effective implementation. Thank you very much. Excellent presentation. Very happy with Dr. Irasola's presentation, clarifying how the panel of experts arrives at these recommendations which we'll hear now. I want to draw your attention to the fact that in this region, we were fortunate to be fully represented in the guideline group, the group that developed the hypertension guidelines. And in the committee, we included Vilma Irasola, Don DePetti, Andres Moran, and Kenneth Connell. All are here with us today, so we are going to have a first-class webinar hearing from those who were right there. These four colleagues were present, representing in the guidelines. But I also want to remind you that Paul Wedren, Patricio Lopez Aramillo, Beatriz Champagne, and Tom Garcia also represented the region in the development of the WHO guidelines. So Dr. Vilma Irasola has set the stage. She showed us that the process was rigorous. What were the recommendations then? So now to present the recommendations of the guideline, I would like to invite you, Dr. Donald DePetti, a distinguished professor of health sciences from South Carolina University in the United States, one of our consultants and Heart's pioneer in the region. Professor DePetti, you have the floor.
And I'm going to hit OK. Hello, I am Dr. Donald DePetty, the Health Sciences Distinguished Professor here at the University of South Carolina and the University of South Carolina School of Medicine in Columbia, South Carolina of the United States. I would like to thank the organizing committee for the opportunity to participate in this exciting webinar. I will be discussing the WHO Guideline for the Pharmacological Treatment of Hypertension in Adults, which was recently released. I will review the specific recommendations and comment on implementation where appropriate. It was an honor to be a member of the Guideline Development Group for this exciting new guideline. Before we discuss the specific recommendations and get into the nitty-gritty of the guideline themselves, it's important to understand the scope and the objectives of the guideline, and that is shown on this slide. The guidelines address issues related to pharmacotherapy with adults with confirmed hypertension. And there were 6 objectives regarding the recommendations themselves, and they're shown on this slide as well. The first objective was, what is the blood pressure threshold to start pharmacological treatment? Secondly, whether lab tests or CVD or cardiovascular disease risk assessment are needed prior to the initiation of pharmacologic therapy. The third objective was, which drugs should one prescribe? And if we choose to prescribe 2 antihypertensive medications together in the initial treatment, which combinations should we consider? Finally, once we started antihypertensive pharmacological treatment, what's the blood pressure target to achieve control of that individual? And again, once we have started pharmacologic therapy and we're seeing the patient, what are the follow-up intervals while we're achieving blood pressure control, but also what are the follow-up intervals once we have achieved blood pressure control in that individual? And lastly, the 6th objective, importantly, was to discuss the use of non-physician healthcare workers in the further management of hypertension. Also, before we review the specific recommendations of the guideline, it's important to also understand how the guidelines were developed and specifically the process. Overall, 3 groups were involved in the development of the guideline. The first group was the WHO Steering Group, which consisted of 11 members. The main body that developed the guidelines, reviewed the evidence, and wrote the document was the Guideline Development Group, also known as the GDG. And this group consisted of 23 members of diverse geographic locations and professions, including the lay public. Once the guidelines were developed and written, the third group was the External Review Group. This was a completely independent group of individuals, separate from the Guideline Development Group and the WHO Steering Group, and consisted of 8 members. We were all thrilled when the guidelines were launched in August of this year. This slide reviews the definitions of the strength of the recommendations from the Guideline Development Group. And you'll see that every recommendation has a strength. There were 2 categories of recommendations. The first category was a strong recommendation. This was a recommendation where the group was confident that the desirable effects of adhering to the recommendation outweigh the undesirable effects. The second recommendation, or conditional recommendation, also probably could be termed weak recommendation, was when the group felt that the desirable effects of adhering to the recommendation probably outweigh the undesirable effects, but not completely confident of these trade-offs. This recommendation, you might also see the terminology used, suggests. Now that we've reviewed the process regarding the development of the guidelines and the definitions used within the recommendations, let's look specifically at the recommendations themselves. And there were a total of 8 different recommendations. And let's start with the first recommendation, shown on this slide, which is the blood pressure threshold for the initiation of pharmacological treatment. There were 3 sub-recommendations within this first recommendation. First, the WHO recommends initiation of pharmacological antihypertensive treatment of individuals with a confirmed diagnosis of hypertension and a systolic blood pressure of equal to or greater than 140 millimeters of mercury, or a diastolic blood pressure of greater than or equal to 90 millimeters of mercury. This was felt to be a strong recommendation with moderate to high certainty evidence. The second sub-recommendation was the WHO recommends pharmacological antihypertensive treatment of individuals with existing cardiovascular disease and a systolic blood pressure of between 130 and 139 millimeters of mercury. This also was felt to be a strong recommendation with moderate to high certainty evidence. Lastly, the WHO suggests pharmacological treatment of individuals without cardiovascular disease, but with high cardiovascular risk, diabetes mellitus, or chronic kidney disease, and a systolic blood pressure of between 130 and 139 millimeters of mercury. This was felt to be a conditional recommendation, but also with moderate to high certainty evidence. There were some implementation remarks, but I just choose to discuss this one. And it was important to note that treatment should start no later than 4 weeks after the diagnosis or the confirmation of the diagnosis of hypertension. However, if the blood pressure is higher, a blood pressure of greater than 160 over 90 millimeters of mercury, or there's end organ damage present, it is recommended to start pharmacological treatment without delay. The second recommendation was whether laboratory testing should be done before and during treatment of the patient with confirmed hypertension once pharmacological treatment or the initiation of pharmacological treatment was to be considered. And the recommendation is as forth. When starting pharmacological antihypertensive treatment, the WHO suggests obtaining lab tests to screen for comorbidities and secondary hypertension. But this is important only when lab testing does not delay or impede starting pharmacological treatment. This was felt to be a conditional recommendation with low certainty evidence. There were some implementation remarks that were included, such as the suggestion of certain lab tests, which could include serum electrolytes and creatinine, a lipid panel, a hemoglobin A1C or fasting glucose, a urine dipstick, and an electrocardiogram. However, remember, when testing is not possible or timely, treatment should not be delayed, and testing can be done subsequently. There were some antihypertensive agents that are more suitable for use without laboratory testing, such as the dihydropyridine calcium channel blockers, and that was noted. The third recommendation of the guideline concerned the determination of cardiovascular disease risk assessment, or CVD risk assessment, as a guide to initiation of antihypertensive medications. And the recommendation is as follows. The WHO suggests cardiovascular risk assessment at or after the initiation of pharmacological treatment for hypertension, but similar to lab testing, only where this is feasible and does not delay treatment. Again, this was felt to be a conditional recommendation with low certainty evidence. There was a discussion of implementation remarks, which are shown on this slide as well. It was acknowledged that most patients with high blood pressure or a blood pressure greater than 140/90 are high risk and treatment is indicated. They do not need cardiovascular disease risk assessment prior to the initiation of pharmacological treatment. However, assessment is still important for guiding treatment decisions in those with systolic blood pressures between 130 and 139 millimeters of mercury, but also to identify other risk factors so that they can be treated appropriately as well. And again, risk assessment should be postponed and included in the follow-up strategy of that individual patient if it interferes with timely pharmacological treatment initiation. The fourth recommendation addressed the drug classes to be used as first-line agents in the initial treatment of the confirmed hypertensive individual. The recommendation stated that for adults with hypertension requiring pharmacological treatment, the World Health Organization recommends the use of drugs from any of the following three classes of medications as initial treatment. This was felt to be a strong recommendation with high certainty evidence and included the thiazide and thiazide-like agents, the renin-angiotensin system inhibitors consisting of the angiotensin converting enzyme inhibitors or ACE inhibitors, or the angiotensin receptor blockers, also known as ARBs. The third class was the long-acting dihydropyridine calcium channel blockers or CCBs. All these classes were felt to be a strong recommendation. Regarding implementation, it is important to consider that long-acting antihypertensives are clearly preferred compared to short-acting antihypertensive agents. Clearly, once a day therapy benefits adherence, persistence of therapy, etc. While these were the three main classes to choose for the initial management of the hypertensive individuals, it was also understood there were other comorbidities or indications to use other medications, and they're spelled out here. The best example would be beta blockers, for instance, for heart failure, ischemic heart disease, for example. Following the fourth recommendation, which was regarding pharmacological therapy and which classes and agents to use, the fifth recommendation was regarding the use of combination therapy or two medication therapy in the initial management of the hypertensive individual. The recommendation is as follows. For adults with hypertension requiring pharmacological treatment, the WHO suggests combination therapy, preferably as a single pill, otherwise known as fixed dose combination. However, if not available, two separate pills clearly could be administered. This is in the initial treatment of the newly diagnosed and confirmed hypertensive individual. Antihypertensive medications used in combination therapy should be chosen from the following three classes, and they are identical to recommendation 4 regarding the classes in the initial management of the hypertensive adult. And they are the thiazide and thiazide-like agents, the renin-angiotensin system inhibitors, again, the ACE inhibitors, the angiotensin converting enzyme inhibitors, and the ARBs, the angiotensin receptor blockers, and the third class, again, consisting of the long-acting dihydropyridine calcium channel blockers, or CCBs. This recommendation was felt to be a conditional recommendation, but clearly with moderate certainty evidence. And the remarks regarding this recommendation included the fact and the observation that combination therapy may be especially valuable when the blood pressure is higher in that individual, such as higher than 20/10 millimeters of mercury than the target blood pressure that is the goal of that individual patient. And also, it's important to note that single pill combination therapy, in other words, two medications in one pill or a fixed dose combination, improves medication adherence, persistence, as well as blood pressure control. The sixth recommendation from the hypertension guidelines revolved around the recommendation on target blood pressures once, of course, initial pharmacological therapy has been initiated and decided upon. And similar to the threshold blood pressures in the first recommendation, they followed three separate groups. First, the WHO recommends a target blood pressure treatment goal of less than 140 over 90 millimeters of mercury in all patients with hypertension without comorbidities. This was felt to be a strong recommendation with moderate certainty evidence. The second group, and again this parallels recommendation 1, was the WHO recommends a target systolic treatment goal of less than 130 millimeters of mercury in all patients with hypertension and known cardiovascular or CVD disease. This again was a strong recommendation with moderate certainty evidence. And lastly, the WHO suggests a target systolic blood pressure goal of less than 130 millimeters of mercury in high-risk patients with hypertension, and they include those with high CVD risk, the presence of diabetes mellitus, and or chronic kidney disease. This was a conditional recommendation, again with moderate certainty evidence. Once pharmacological therapy has been initiated and or felt to need to be titrated, the seventh recommendation revolved around the frequency of patient or individual assessment. And it consisted of two components. The first was the WHO suggests a monthly follow-up after the initiation or, importantly, change in antihypertensive medications until the patient reaches target. This is a conditional recommendation felt with low certainty evidence. It's important to note that while a monthly follow-up was recommended, it is at least 1 month. The patient can be seen clearly more frequently or sooner than 4 weeks, if you will. There was also a recommendation that the WHO suggests a follow-up of every 3 to 6 months for patients whose blood pressure is under control. Again, with a conditional recommendation with low certainty evidence. Thus, we have recommendations while the patient is being titrated and control is being targeted, if you will, but also we have recommendations for how frequent to see the patient once control has been achieved. The eighth and final recommendation from the guideline was a recommendation on treatment by non-physician professionals. In this recommendation, the WHO suggests that pharmacological treatment of hypertension can be provided by non-physician professionals, such as pharmacists and nurses. However, as long as the following conditions are met: the individuals have proper training, they have prescribing authority, there are specific management protocols or algorithms, and importantly, there's physician oversight. This was felt to be a conditional recommendation with low certainty evidence. And it was noted in the implementation remarks that community healthcare workers may assist in tasks through a collaborative care model, the so-called team-based approach that we talk about. The scope of care depends on local regulations, however, and that's important. Telemonitoring and community or home-based self-care are encouraged as well. And finally, physician oversight can be done through innovative methods, such as telemonitoring or similar methodology, to ensure access to treatment is not delayed. Again, that treatment is initiated in a timely fashion. Now that we have reviewed the guidelines themselves, which included the scope and objectives, the development process, and importantly, the specific recommendations themselves, let's conclude with some closing thoughts in general, not only regarding the new WHO guidelines, but also more recent guidelines from other societies, countries, etc. These are my thoughts, so I want to take ownership. I think what we're seeing is lower and lower blood pressure pharmacological treatment targets and thresholds. That has been relatively consistent. We're also seeing the increasing use of cardiovascular risk in blood pressure treatment decisions and thresholds. As you can see in the WHO guidelines, there are different thresholds and blood pressure targets depending on the presence of high cardiovascular risk or existing disease, etc. While I did not mention for the sake of time and highlight standardized algorithms and protocols, it's important to note that they are included in the guidelines themselves, and they can be found in the guidelines, specific examples, if you will. And that's just highlighting the increasing importance of the use of standardized, straightforward, and simple treatment algorithms and protocols in the management of the hypertensive individuals. Additionally, there was stronger consideration noted for the use of two medicines, two pills, or even better yet, a single pill fixed dose combination in the initial treatment step of the hypertensive adult. We are seeing this in other recommendations as well, and I think this has been a consistent trend. And lastly and importantly is the importance in achieving blood pressure control of utilizing a team-based approach, which includes timely patient follow-up and implementing, again, as I mentioned, a team-based approach using all members of the team at the level of their expertise. I would be remiss if I did not say it was an honor to be a member of the Guideline Development Group, or GDG, of these new WHO hypertension guidelines. I would also like to thank you for attending the webinar. And a very, very big thank you and shout out from the University of South Carolina School of Medicine here in Columbia, South Carolina.
Bueno, excelente la presentación.
Excellent presentation. I am certain that we will have a great level of detail of debate regarding this topic. I am going to invite Vilta and Don DePetti to please turn on their cameras for the question and answer period. It would be a good idea to see Professor DePetti, Vilma. The table is set. I am going to start asking you the following. Vilma, do you know that now we have some discussions on the guidelines, people have different opinions on this and that, but when applying a great methodology, that is to say the methodology with all of the characteristics to be as rigorous as possible, when individuals see this and they say, well, moderate certainty or conditional recommendation, some individuals tend to think that this is not that strong, but this shouldn't be done this way. What is your opinion? What do you think that as an expert, how can we better understand this? Please go ahead. Thank you, Pedro. I share the same concerns, and as a matter of fact, as you mentioned, many of us who participate in this guideline committee are here at this meeting, and there was a great deal of debate and discussion as to how to use the evidence, how to assess it with all of the methodology, and what to do with the results. As a matter of fact, I believe that, as you said, that strong evidence has to do at the current level of knowledge. It doesn't make any sense to second guess it, and we hope that the standard of care follows that recommendation. Now, what happens with the moderate level of evidence and the conditional recommendations? In my opinion, the issue with conditional recommendations is that there could be variability according to the context and the implementation context in particular. Then, in my opinion also, conditional recommendation is preferred to weak recommendation, because if they were weak recommendation, they would not be part of the guidelines. These are conditional recommendations. Conditional to what? Conditional to circumstances that may change according to the context. For example, depending on cost, availability of certain tools that imply that in one context we may use these recommendations, conditional recommendations, as they may be called, in a more complete or less complete fashion. That is the big difference. That is to say, if the recommendation is strong, we should not address it. If we're saying 140/90, let's stop the discussion right there. Let's continue with something else. Now, if the recommendation is conditional, then, well, beware. In different circumstances, the probability and the possibility of applying them may vary too. That is the most significant difference if I had to sum it up in one sentence. I think this is an important moment. Vilma has reminding us of this, and we have now thousands of individuals who are attending this webinar. This webinar will be recorded, is recorded, and will be uploaded to the WHO webpage as well as on YouTube. It will be uploaded to the PAHO channel. I have been inviting the academic authorities that participate in this webinar to take this material and to take it to the universities to use it as consultation material. See the privilege of having Vilma and Professor Di Petti, who are members of the committee, and they're listening to them live. So this is not just for them to be told what they said, but they are here to tell us what happened in first person. So Professor Di Petti, Vilma already said it. So 140/90, and there is nothing else to discuss. And she's saying that if the goal of control is below 140, there is no discussion, no need to continue this. And I think that this overcame an important barrier that we had. Let's wait 6 weeks, let's wait for non-pharmacological treatment, let's wait for the lab treatment or the lab diagnostics. I think that the guideline is also giving us the idea that we need to take into account the importance of considering the severity of the issue, because if something is 140/90, if pressure is 140/90, we know that this is urgent. And someone in the chat is asking me, whether this is the same for the elderly, but I think that this is depending on the evidence, correct? Professor Di Petri, you have the floor.
Let me take the last point first, Pedro. Clearly, the guideline states, and you can, it's obvious, there is no mention of age. And the reason being is that the evidence is clear that independent of age, let's just take the blood pressure of 140/90, that pharmacological treatment is indicated. There's strong evidence to support doing such in a timely and rapid manner. Now, again, remember guidelines as well as recommendations are for the general group of individuals. There's always an exception. And there's always an individual, an older person that's frail, for instance, or an older person that's institutionalized. Clearly, they can be and probably will be treated in a different manner. But these recommendations and guidelines, and it's really important to keep emphasizing, is for the general adult population. And then there are sub recommendations for individuals with high cardiovascular risk, diabetes, CKD, and the presence of CVD, et cetera.
Vamos a quedarnos en esa última parte.
We are going to take what you said last, because this guideline has been very strong on 140/90, as long as you do not have cardiovascular risk or any other cardiovascular condition, if you do not have diabetes, etc. But we then find room to improve hypertension in diabetic individuals with diabetes. And I would like for you to reinforce why we need to have less than 130, not for the cardiovascular risk to tell you whether I need to start or not with treatment, but to establish stricter or goals and controls for follow-up. Please, Dr. DiPetti, go ahead.
To me, the reason to have differing goals is obvious in these groups of individuals. First of all, they already have cardiovascular disease. That's in the individual that we already know has cardiovascular disease, has had a stroke, has had coronary disease, has had a myocardial infarction, et cetera. But there's also groups of patients like the patients with diabetes, mellitus, and CKD, which are in themselves atherogenic time bombs, just waiting to happen. And we know that they already have existing cardiovascular disease if we were to do more specific evaluations, et cetera, but they haven't had that event yet. That is why they are, although the recommendations were separate because the evidence is stronger in those with existing CVD to treat 130 to 139, the conditional recommendation was put in place to also then acknowledge the importance of the individuals with diabetes mellitus and chronic kidney disease.
Muy bien, excelente.
Very well, excellent. I think that the whole webinar should have been used to address these questions. I have many more questions, but we need to move on to the next block. But I just wanted to conclude here with Vilma and also for our panelists from the first group. Do you know that many sites have also presented some concerns about non-medical health workers who would be in charge of heart patients, but as a researcher, you had shown the importance and the evidence that we have behind working ladies. We have between 40 and 50% of the population that has hypertension. All of the doctors in the world do not be enough to treat hypertensive patients. So what is the importance of this recommendation? It is a policy recommendation, but at the same time, it is an evidence-based recommendation. Vilma, I give you the floor again. 100%. I agree completely with what you are saying, Pedro. The experience is growing, increasingly showing us the importance of the work of non-medical staff, nurses, also health promoters and health agents who are working within the community, carrying out activities that have to do with screening and follow-up of problems. They're also looking into medicine adherence. So there are many problems that are in the good hands, that are in good hands when they are in the hands of non-medical staff, without any doubt. I am a doctor, but I would dare say that they are better managed than if they were managed by doctors. When we're talking about those conditions, those situations, there is large evidence, there is growing evidence, and also very interestingly, we have evidence in different contexts. This is something that is growing universally. This first block has been thought-provoking with Vilma, DiPetti, and I think that the guide itself is thought-provoking, but we're going to see now what the next block of experts has to say. But to give you an example of what is going on in actual life, now in real life, let us now see what happens in Trinidad and Tobago, how it is done, and the advantages in this context of implementing WHO guideline. Now let us look now at the material we have on Trinidad and Tobago. Please go ahead.
Trinidad and Tobago has a rich history due to its multi-ethnic community. Our cultural expressions in both food and entertainment make us proud. But our modern way of life, unfortunately, leaves the population vulnerable to chronic conditions such as hypertension. Care for persons afflicted with non-communicable diseases can be a daunting task, as healthcare systems lack the resources for NCD management and have many competing priorities. But with the Hearts Initiative, we are reorganizing how care is provided at the primary care level.
The Hearts Initiative provides a holistic approach to chronic non-communicable disease management. incorporating both public health and clinical primary care in one program. At a population level, PAHO works with the Ministry of Health and technical experts, such as primary care experts, cardiologists, and nephrologists, to tailor-make a treatment algorithm that works best for each individual population. This takes into account access to medication while minimizing side effects and ensuring ease of access, as well as reducing the number of physical pills needed.
Trinidad became a part of this Global Hearts Initiative in July 2019. And it's a partnership between the Government of Trinidad and Tobago and the Pan American Health Organization and the World Health Organization. The Hearts Initiative is a new way of delivering health services, reforming the way in which we currently deliver health services in the primary healthcare setting.
The Hearts in the America initiative is a global drive for strengthening the health system to provide better care for NCDs at the community and individual level. The government of Trinidad and Tobago has been pleased to work with the Pan American Health Organization and World Health Organization since 2019 in reorganizing the provision of care and scaling up of the implementation of this initiative.
This program is part of the government's attempt to get the population to be healthier, to take charge of their health. And let's reverse the burden from being a treatment-based model to a preventative-based model. Take control of your health. But also, we want to start to treat our children and train our children not to make the mistakes that their parents and grandparents made. So that is why we have a whole program about childhood obesity and childhood health. It's a game changer to change the culture of the way we treat with NCDs in Trinidad and Tobago.
For one, it's making it easier to follow our clients. You get better satisfaction and you get results in a faster time. Previously, what happened, independent physicians or different physicians will see clients and they will treat clients in accordance with their knowledge and what they have seen worked for them over the years. With the standardization of the treatment, what you find is that we follow an algorithm, we follow a set protocol that can be followed by the clients, their relatives, as well as the physicians themselves.
The Hearts Initiative is a team-based approach at its core. The patient will come into the health center. The first line of contact is the clerk, who will send the notes to the nursing assistant, who is also the screening nurse. The patient, of course, meets the screening nurse as well. Where the blood pressure is taken, a short history is done. The nursing assistant or the screening nurse will take the patient and the notes to the doctor, where the patient is interviewed and further counseling done. Medication may or may not be changed. The patient is then sent to the district health visitor or the nurse associated with the program. There the patient receives a greater amount of counseling done on lifestyle changes that can be made improvements. The nutritionist in the Hearts-based team effort will advise the patient on the meal changes that need to be made in order to lower the blood pressures. Simple little changes or maybe big changes. From there, the client will leave the nutritionist and head to the pharmacist, where he or she is given medication as well as advice on how to use the medication. The client then returns to the starting point of the clerk, who reminds the client the appointment time, the appointment date for the next visit, and any further visits that may be required, as well as reminding the client to come in for the next prescription.
So we are working to support the Ministry of Health. And beyond that, what we're working to do is actually to help strengthen health systems in Trinidad and Tobago. The reason for us working with the ministry, which is our line ministry, it's because we support the Ministry of Health in taking care of persons with non-communicable diseases. And we are doing that within the context of strengthening health systems overall, which is a critical part of the work that we do at the country level. So the Hearts treatment protocol is a standardized protocol that will be implemented with persons with NCDs.
They told me then that my blood pressure was too high and that situation has to be addressed and corrected by a change by medication and a change in lifestyle and what I do. That's when I decided to join the heart group here. I was advised that I need to start testing my blood, recording it, so that I can see which way it's heading, whether it's improving, whether it's getting worse, etc. Among the things I needed to do was to change my diet, because that was a major contributing factor. What was interesting is that the testing now, I got on the way with my testing of my blood pressure, and I started to see the drop that is taking place. Like when I started off, my blood pressure was 155 over 96, and at present it's 123 over 75, and it kept coming down and down. And when I discussed this with medical people, they said that present blood pressure rate is quite good. Just keep it there.
Bueno, excelente este material para ilustrar.
Excellent material to show what we were saying. Just one little detail. This revelation of this final patient, the last part of the picture from Trinidad and Tobago, is impressive. He says, I have less than 135. So he said, I have less than 135. So the doctor said, yes, your pressure is much better. So how illustrative this TNT material, and it places us right into the second block of today's webinar. And this second session of today's webinar is going to bring us to work with two essential topics. The first, the relationship between COVID-19 and high blood pressure. And I have the pleasure of introducing Professor Kenneth Coleman, Vice Dean of the Medical Sciences in West Indies University in Cave Hill campus in Barbados. Professor Kenneth Coleman, you have the floor.
So thank you very much for your kind introduction, and it's a pleasure to present to you from sunny but slightly overcast at times Bridgetown, Barbados, here in the Caribbean. My name is Kenneth Connell. I am a hearts consultant as well as a full faculty member at the University of the West Indies Cave Hill campus here in Barbados. Over the next 7 minutes, I plan to take you through a very short menu looking at COVID-19 and hypertension. The 4 points to be covered include: what is the impact of COVID-19 on hypertension care? What happens if we do nothing? What are some innovations in care delivery? And will we ever return to the past? This diagram shows a delicate overlap of factors influencing care in the COVID NCD hypertension landscape. The Venn diagram shows discrete entities, but there are several overlaps. So COVID-specific factors are there. Indirect health system factors are there as well, dating way before COVID, of course. And finally, there's direct health system factors as well. And whilst we are all accustomed now of looking at the various waves of COVID-19, first, second, third, in some instances, in some countries, fourth and fifth waves, we might want to categorize these in terms of the types of waves that are seen. So for instance, the types of waves that we are currently examining are the infection waves, and this is very relevant and important in a pandemic. But consider the other types of waves, such as the NCD waves, when patients with chronic conditions will present after the pandemic, the so-called second wave. The third wave, patients with long-term conditions, including some NCDs, and of course, the fourth wave, which has already started, and that involves psychological stress, economic injury, and the whole mental health issues that are involved. So whilst we are focused rightfully on a pandemic of an infectious disease, there are several other types of waves that are approaching. My own small island of Barbados currently, or a large teaching hospital is currently experiencing such a wave. The number of acute presentations from complications from NCDs, especially hypertension-related presentations such as stroke, as well as heart failure, have increased, in many instances at a 200% increase in admissions to our hospital. All this, of course, is matched with the fact that many of our healthcare workers, initially meant to staff the one teaching hospital in Barbados, have been contracted and are being diverted to COVID efforts in, for instance, purpose-built facilities such as isolation centers and quarantine centers. So the hospital is already operating at a skeleton type staff, and in Hearts, I suppose we might call this kind of task shifting, but of course what happens is that with minimal numbers, it has an impact on the standard and quality of care. WHO published this very interesting graphic which showed the interruption of services in 120 countries, reported their NCD services being disrupted. If you look carefully, you don't even have to look carefully, at the major ones being disrupted, as much as 60% in one case, rehabilitation care, such as cardiac rehabilitation. In Barbados, for instance, the cardiac rehabilitation gym at the Heart and Stroke Foundation of Barbados was paused for almost 6 months. Patients did not attend. And of course, acute presentations from complications such as heart failure and uncontrolled hypertension, as well as some other cardiovascular diseases, then presented to the acute care facility. Of course, since then, the facility has moved to remote care and remote monitoring of patients, remote cardiovascular rehabilitation. Not surprisingly, hypertension clinic is a convenient clinic for a hospital that is stretched to kind of cut back on the resources and divert them towards COVID-19 as well. And so in my own resistant hypertension clinic, a lot of staff have been diverted to isolation centers, and the clinic has been either shifted to completely remote, or in many cases there have been sudden cancellations, especially during surges of COVID-19. It's no surprise here then, it accounts for about 50% of countries then claim that they had disruption of services in hypertension care. And it just continues across the other NCDs. So for instance, diabetes, asthma care, palliative care, urgent dental care as well as cancer treatment. This other graphic shows the percentage of countries reporting disruptions in NCD care as well. And if you look carefully and using various health services metrics, you see that the average disruption in the service group, for instance, 15%, 11%, and 19%, using the code, the bright yellow showing 5 to 25% disruption, the orange 26 to 50% disruption, and more than 50% in red. Again, you can see large-scale prevention, chemotherapy programs and campaigns were extremely disrupted, as well as community awareness and health education campaigns, support for self-care, rehabilitation, and psychological services with patients with chronic NCDs, diagnosis and treatment. All the things that we have done were significantly impacted in many of these countries, but especially the arrangement for drug therapy. In our country, for instance, there have been several shortages in procurement of various drugs because of the pandemic. Direct effects of shipment into the country, all those factors resulted in not just moving from the perfect algorithm or the ideal algorithm to the preferred algorithm, but sometimes there were shifts to some drugs that were just happened to be available in the country at that point in time. So the vulnerability in a small island developing country like Barbados was quite evident once a pandemic hit. And of course, it's not surprising then that the Director General of WHO stated many people who need treatment for diseases like cancer, cardiovascular disease, diabetes, have not been receiving the health services and medicines they need since the COVID-19 pandemic began. It's vital that countries find innovative ways to ensure that essential services for NCDs continue even as they fight this pandemic. And hence my analogy of the burning platform. The burning platform is an analogy used in business. It's also used by one of our other heart consultants, Don DePetty. But the burning platform really does exemplify an urgency and an opportunity for innovative change. There is usually an acute presentation, in this case a pandemic, which disrupts or threatens to disrupt the status quo, the health services and health systems. There's an opportunity for innovation, which businesses capitalize on, and they use this to create smarter business platforms and more efficient platforms. And of course, there's auditing to see what improvement has occurred over time. These journals just support one possible innovation to address the burning platform, and that's telehealth and telemedicine as part of telehealth. And I've just cited some of them here from the Journal of Urology, as well as New England Journal of Medicine. It's been quite topical in the medical literature. Some of the titles: Virtually Perfect, Telemedicine for COVID-19, Implementing Telemedicine in Response to the COVID-19 Pandemic, and my favorite one here, Keep Calm and Log On, Telemedicine in the COVID-19 Pandemic Response, from the Journal of Urology here. So telemedicine is one possible intervention for us to consider in this whole heart's pandemic, COVID pandemic, but hopefully heart's pandemic as well. And this schematic just shows the relationship between various factors, both in hospital and home, that lend themselves to remote monitoring, such as rehabilitation, as I was mentioning in an earlier slide. And what I'm going to move on to is one example in closing, and that's the use of telemedicine in terms of mobile health, using smartphone technology, remote blood pressure monitoring, and in some cases remote weight monitoring as well. So before the pandemic, almost fortuitously in Barbados, we started what's known as the HYPE program. This program was funded largely by private sector, and patients and staff at our hospital received these mobile eye health monitors. Of course, they did not get a smartphone, but they all had smartphones to use in collaboration with the monitor to allow for remote monitoring. And this is seamless. So the readings received, as shown here in this slide briefly, there's an individual patient profile. Patients do readings twice a day, or sometimes they're advised 3 times a day. There's an entire database of patient data showing their blood pressure monitoring or any other circumstances that they might report, such as feeling unwell today or had my COVID-19 vaccine, those kind of things. And this allowed healthcare professionals to track patients' blood pressure remotely, which then kind of removed the need for them to come into a hospital to have a hypertension visit, only to have their blood pressures checked and for medication to be continued. And this is such an important kind of collaborative or dovetailing event with hearts in the Americas, because with a standardized algorithm, which patients are already aware of and you, the practitioner, is already aware of, and also, more importantly, a non-traditional or even non-traditional as well as unusual locum doctor might be in your clinic or practice at that time, but can follow a simplified algorithm and knows exactly how to escalate care based on remote readings. Whatever telemedicine platform is used, whether it's something like a free platform like DoxyMe, or a lot of other models are available in some of the other countries, certainly here in the Caribbean as well. There is a whole set of telemedicine platforms to choose from, but whichever one you use, the combination of remote monitoring, whether it's sophisticated mHealth or even just using the home blood pressure monitoring at home and readings coming through to the healthcare practitioner, makes a huge difference. And so to close, I'm going to suggest that there is a kind of a quartet of factors that might be driven by a pandemic if you want to see a positive side from a disruption of the healthcare or a burning platform from COVID-19. Telehealth in combination with a structured program for standardized algorithm, availability of drugs, and facilities to enhance care and monitoring. I'm going to just add in there a platform as well, a standardized algorithm. I've chosen that random Trinidad's algorithm here, but of course, whatever Hart's algorithm is being used in your specific country. And finally, of course, the WHO guidelines could all act as the perfect ingredients, really, to a recipe in innovative healthcare and remote monitoring of hypertension during COVID-19 pandemic. I thank you very much, and I'm going to end my presentation here. I'm looking forward to discuss with you some of your thoughts in the panel discussion. Thank you.
Muchísimas gracias.
Thank you so much, Professor Kenneth Connell from Barbados, from the West Indies University, and for his dissertation on the subject of hypertension and COVID-19. But before I get into our next speaker, I'd like to greet a group of colleagues from different countries and welcome the countries again. When we did the webinar a month ago, we were welcoming, as I said, what the new countries were. Now, formally, we welcome Guatemala and Bahamas and Dominica. And we are getting to know each other. In the next few days, if everything goes well, we'll have a new member from countries implementing HARTS, which is El Salvador. And we'll have 20 countries making an effort to implement HARTS. Now that we're saying that it's more important than ever, because we are responding to the pandemic, because in many countries, the pandemic has been a chance to advance in different ideas of ways to get out of the pandemic. Using some of these ideas, I'm going to go back to Professor Kenneth Connell in a minute and talk a bit more about the technology. But now I'd like to introduce my next guest in this block, Professor Andrew Moran, Director of the Global Hypertension Control Program in Results to Save Life, one of our panelists and one of our key donors. So I'd like Andrew Moran, who's a professor in Columbia University. I want him to tell us about one of the topics of the guideline, which is definitely an innovation for WHO guideline, which is the presentation of an algorithmic approach of hypertension treatment. So, Professor Moran, Andrew Moran, you have the floor.
Greetings, I'm Andrew Moran. I'm the Director of Global Hypertension Control at Resolve to Save Lives and an Associate Professor of Medicine at Columbia University. I also served on the Guideline Development Group for the WHO 2021 Guideline for the Pharmacologic Management of Hypertension in Adults. Today I'm going to talk to you about translating the WHO 2021 guidelines into action and algorithmic approach. Now, earlier you heard about the main recommendations of the 2021 WHO Hypertension Guidelines. And also, in the same document that was published by WHO, they included implementation tools, specifically Section 6 of the document. And in this document's implementation tools section, there are recommendations for an algorithmic approach to treating hypertension, and included are drug and dose specific protocols. These drug and dose specific protocols actually include all of the main recommendations of the main guideline, including guidelines recommendations 1 and 6, BP thresholds and goals, guideline 4, preferred antihypertensive medicines, guideline 5, the use of initial combination therapy, guideline 7, frequency of patient follow-up, and guideline 8, the use of team-based care. Even within these one-page treatment protocol documents, all of these guidelines are synthesized together. Now you know that the World Health Organization, PAHO, and Resolve to Save Lives all recommend the use of simple treatment protocols in hypertension control programs. Why? Because these treatment protocols improve hypertension outcomes. The precise protocols establish standard treatment of patients based on guidelines and adaptive to local manufacturing and procurement landscape. These are drug and dose specific, using the preferred drugs with a schedule for titration and addition of additional drugs if blood pressure is not yet controlled. These guidelines do more than dictate how treatment is delivered. They also ease logistics, training, they enhance the use of team-based care and task sharing, and they simplify supervision, financing, program evaluation, and adaptation of new changes in the clinical landscape. Now, on the right of this slide, you see an example of a simple treatment protocol developed for the country of Bangladesh. In this protocol, which only has 4 steps, there are only 3 medicines used, and all at a single dose. This is such a simple treatment protocol that it can be easily learned and utilized by non-physician healthcare workers. Now, in Section 6 of the guideline document for implementation tools, there are recommended algorithms for hypertension treatment. Generally, the recommended algorithm is initial dual drug combination therapy. And this algorithm, for example, might start with a calcium channel blocker combined with an angiotensin receptor blocker. And then in the second step, for uncontrolled patients on the first 2 drugs, you might add a diuretic as the third drug. The alternate algorithm begins with initial monotherapy. This might be calcium channel blocker with the ARB added in a second step, and then in a third step, the diuretic for those patients who remain uncontrolled after the first 2 steps. Now, in the guideline, these algorithms are translated into drug and dose specific protocols. Again, the recommended protocol would begin with initial combination therapy at the first step. In this case, telmisartan combined with amlodipine. Those drugs are started at their standard dose, doubled in the second step, and it's at the third step where a third drug, a diuretic, is added. Now again, the alternative is an initial monotherapy protocol, but it's important to mention that even in the initial monotherapy protocol, by the second step, there's an opportunity to use a single pill combination where 2 drugs are recommended to the patient. These simple guidelines may appear to be quite basic, but it actually requires a great deal of effort by a lot of stakeholders to come together to decide on this simple treatment protocol. In this protocol development process, stakeholders like local clinical experts, pharmacy experts, experts in supply chain and procurement, and government and other stakeholders who manage the hypertension control program will need to be involved in that consensus process. The PAHO Hearts in the Americas program has also developed protocol development tools which drive transitions from an acceptable protocol to an ideal regional standard. The acceptable protocol at the beginning of the program might be limited by the availability of the preferred drugs, including limited availability or high price of single pill combination medicines. But the ideal is, over time, the country will arrive at the ideal protocol as the prices for these preferred agents are lowered and the drugs are made more accessible. In addition to those tools, WHO, PAHO, and Resolve to Save Lives offer a number of other tools that can assist implementing teams with developing a simple protocol for their country. First, there is the WHO Hearts or Evidence-Based Protocols module that outlines the rationale for using these simple protocols. There is also a Hearts Protocol Consensus Conference Guide that guides teams on how to develop a consensus conference that involves all of the local stakeholders and then in the end arrive at the consensus needed to support the simple protocol. Resolve to Save Lives, as part of its 6-step guide to implementing hypertension control programs, in step 2 offers some templates and country examples of simple treatment protocols. And lastly, the PAHO Hearts in the Americas website offers several tools, including current and preferred country protocols for a number of countries in the region, as well as a list of the PAHO Strategic Fund preferred drugs, including single pill combinations. Before closing, I want to invite you all to enjoy LINKS, which is a global community for cardiovascular health via an online platform. And if you can sign up via the website shown on the slide, you can join the LINKS community and have access to training materials, webinars, and other information about cardiovascular health and NCD control programs around the world, and network with others who are working in this space. With that, I want to close and thank you for your time. It's been a pleasure to present this talk on an algorithmic approach to implementing the 2021 WHO Hypertension Guidelines. Thank you.
Bueno, excelente.
Excellent. So exciting, this webinar. So many different areas we're covering, so many wonderful things we're reviewing. I'd like to invite Professors Andrew Moran and Kenneth Connell to open their cameras because we have questions for you. You know you're not going to get away from getting some questions. How exciting that we're coming to this, and to not miss the impulse. Well, no, first I want to remind you who we have. We have our colleagues from CDC who've been our partners and our donors as well in the Hearts for the Americas program. Kaiser is with us, and Linde Jose from the CDC are hearing and participating in the public. We have the coordinators from several countries of Latin America. We have 300 people online, and we have the YouTube channel open as well. And as I said, those of you who are here, professors, I suggest that as soon as this webinar ends, you record this, you download, well, no, don't record it. We're recording it. You download it and share it with your students because the material is first class. Imagine, we have Andrew Moran here and Kenneth Connell, who were in the WHO guideline team, and they weren't told what happened. They were there. They knew what was happening. And look what qualified people to talk about the things I'm going to ask them about now. I'm going to ask Andrew now so that we don't let him get too cold after he finished his presentation. The topic of the combination of two drugs is a reality. There's no way back. Is it true that there's no way back? The people are asking, well, how do you do it? Is it true that there's no way to go back with it from the combination of drugs, and that finally the WHO now has drugs in a list of drugs, and the guideline recommends that we start treatment with combined pharmacotherapies? Dr. Andrew Moran, can you tell us a little bit more about this?
Yes, I'm happy to talk about this, Pedro. And first of all, thank you so much, everyone, for attending today. It's really a great pleasure to be part of this group and this movement around the 2021 guidelines. And yes, can someone stand in the way of progress? Absolutely, they can. You know, it's true for all scientific progress. There will be people who are reluctant to adapt the new evidence and the new guidance. So really, that's why we're having these webinars. I think that in the clinical community, there will be some people who were trained years ago to start with a small dose of medicine and slowly work their way up to a higher and higher dose. This, as we know, can take many months and leaving the patient with uncontrolled blood pressure during that time if the patient comes back to clinic. So this use of combination drugs, now the evidence is with us. Not only the trials that show that it works and it's safe for lowering blood pressure, but now there are increasingly a number of trials showing that it prevents heart attacks and strokes compared with using the single drug monotherapy. So I think, as you've seen in these polypill trials that are coming out recently published. So yes, the evidence is with us, but it's our imperative as the leaders of this movement around the guidelines to convince the local clinicians that it's safe and it's time to transition to these combination meds. Now, the other part of the resistance is the pricing, and we've got to rally ourselves around this algorithmic approach that I discussed, so that we're using the same preferred medicines. By having the same preferred medicines, the market for the medicines becomes larger and there is more leverage to lower the price from the pharmaceutical companies. So really, there are some places where we have a lot of work to do. It won't come automatically when these guidelines are released that the combination medicines will be accepted. Over.
Okay, precisely. That's why we are insisting so much, Andrew, on the guideline and hearts. And if you notice at the end of this month, on October 29th and 28th and 29th, the heart countries are, well, right now they're in the midst of an evaluation, identifying the improvement lines of their protocol. Now each country has their own protocols, and we're going to try to find the improvement points of that protocol and align the guidelines and go towards a better control of our hypertension in the region. I want to remind you, it's not good news. I like to give news, but I also think it's important to shake you sometimes. You know how many people have controlled hypertension in the region? I'm going to tell you, only 35% of women and 23% of men. With the amount of therapy we have, with the guidelines we have, with the enormous effort we're making, where's the failure? 35% only of women and 23% of men.
So this should make us think. We are not going to lower mortality due to cardiovascular disease if we do not control blood pressure. So this is the question for Andrew. The key function of algorithms for the organization of health services. This is not only a medicine problem. The algorithm goes beyond medicine. This is an instrument to organize the health services. Could you please elaborate on this?
Absolutely. Yes, at Resolve and in PAHO and the other partners working around the world on these hypertension control programs, we do believe in a simple approach. As a matter of fact, in our work with organizing quality improvement groups, working in primary health centers in India, in Bangladesh, in Ethiopia, in countries in the PAHO region, and I know there's a quality improvement team working within the PAHO program. We take lessons from anywhere, including from the automobile industry. It's really from industry where they learn to take the simple approach of using feedback and quality and continuous quality improvement to make the program more accessible for patients, to make it easier for the providers to deliver the care. So absolutely, there's much work to be done, but I think taking this kind of approach with continuous improvement, using a team-based care and the preferred medicines recommended by the guidelines, I think we can make great progress, but we do have a lot of work to do, like you said, Pedro.
Thank you very much, Andrew. Now I am going to give the floor to Ken. I have some observations for your presentation. Let's see. On the one hand, this is related to whether the pandemic has a positive impact. That may be for later, for a discussion between you and I, because the truth is that we went through very bad times with health measures, with with social distancing, with vaccination as soon as available. These are essential health measures to help patients with chronic diseases. And the other topic that I would like to address again has to do with technology. Technology is very good and it could be also very detrimental. We all know. So we are talking at heart. Yes, to technology and clearly blood pressure monitoring on an outpatient basis, but with automatic and validated devices. This is something that is open for discussion. So we need to think of validated, automated devices for an accurate diagnosis and an accurate follow-up of that person that has a blood pressure issue. So Ken, let's go back to you. What do you think? Is telemedicine here to stay among all of these inventions that we try to find to overcome the difficulties of the pandemic? Please go ahead.
Thanks, Pedro. So we could not have been living in a better time and possibly a worse time than being in the middle of a pandemic. It's the perfect burning platform for us to be innovative. So the two examples that I cited, for almost half a decade, we've been discussing about having remote rehabilitation care. And that's all we've been doing, discussing it. And the only thing that got us moving towards it was actually the fact that it was impossible to have face-to-face visits in a rehab gym. The hypertension clinic, the same thing. At my hospital, we've been discussing it as well. Wouldn't it be a lot more convenient for patients, and will we not get them to target faster if we use technology? But there wasn't a burning platform. And now that there is, I think it's an important opportunity for us not just to see the simplified algorithms as there and easy to follow by patient, by healthcare provider, even by the relative in the background of the living room following the algorithm. But we have to kind of marry that with the environment that we're in. And that's a telemedicine environment. So direct response to your question is, I hope that we will not be going back to the way we were pre-COVID in terms of the way we manage patients. Yes, face-to-face visits are important. Telemedicine visits offer unique opportunities to engage with the patient in their home environment. No one can say, I forgot my blood pressure diary at home, because you are at home. There's also the fact that you get involvement of relatives and the support structure is there. It's convenient, you can rapidly escalate drugs. But what is more important, this would not be possible, and I really want to emphasize this, aside from the two important contributions from HEARTS, and that is the simplified algorithm and the adoption of automated devices. Imagine if we were still pushing the mercury auscultation devices, how difficult this would be. And those are important innovations that come from HEARTS that marry with telemedicine.
Muchísimas gracias. Bueno,
thank you very much. Incredible. Has Andrew raised his hand? No.
Yeah, I just, if there's time, Pedro, I want to add to what Dr. Connell said. I totally agree with everything he said. There's another kind of telemedicine that's not between the healthcare provider and the patient, but between healthcare providers. And that's also something that we've seen growing exponentially during the pandemic. And what this means is that a nurse or a non-physician provider who's in the community clinic can communicate with the doctor who is in the hospital or the remote facility. And this brings care closer to the patient's doorstep. And this is sometimes by using text messages. It's not by, you said, Pedro, everyone's thinking of these very fancy technologies. It can be very basic, but we are seeing that as well. And that's another thing to mention in addition to what Dr. Connell was discussing.
Andrew, I completely agree with you. And also in a setting where doctors have been shifted to other roles in the pandemic, it's so critical to be able to have that kind of relationship between the two on telemedicine.
Bueno, déjame decir una cosa. Una de las cosas que caracteriza
Let me tell you something. Passion is one of the characteristics of people here participating in HEARTS. Webinars are never enough. The time is never enough, but we need to continue. But we are ready for the third block. But before we move on to the third block and we thank these super experts, Kenneth Connell and Andrew Moran, before we do that, we are going to show you a video that we will be presenting the risk calculator for cardiovascular risk of hearts in the Americas. Please go ahead. interpreter apologizes. There is only text, and at the speed of the showing of these slides, it's impossible to interpret, and the text is in Spanish. We apologize, but we cannot interpret this.
Excelente, y estamos de regreso.
Excellent, and we are back here for our third section today. Yesterday, we met with our partners to work on planning, and some of the questions we heard from the countries is what were the barriers for the development of hearts, and also for the implementation of the new WHO guideline. And many referred to this and said, well, doctors are a problem sometimes at the time of implementing a guideline. We are trying to look for is not on the guideline. And oftentimes, this interrupts what we are doing. And just to show you that this is going to change and this is not the way it will remain, here we have the presence of the presidents of three very influential associations: nephrologists, cardiologists, and the World Association of the World Stroke Organization, that they are all working closely with these individuals and hypertension. I am going to introduce Álvaro Sosa Lipandri, who is the new president of the Inter-American Society of Cardiology. And we also have Alejandro Ferreiro, that is also a member of the Latin American Society of Nephrology, and also Sheila Martin, who is the president-elect of the World Stroke Organization. Please go ahead. Esteemed colleagues and friends of the Americas, my name is Álvaro Sosa Lipandri. I am the president of the Inter-American Society of Cardiology. I'm talking to you from Argentina. I thank you for this kind invitation that allows me to be with you in the launch and presentation of this important guide of the World Health Organization on blood hypertension. I think it is highly important, in particular, the issuance of a document of this sort, taking into account the importance of hypertension in our region, as we have already heard, the level of diagnosis, but also the control and treatment of blood hypertension, of blood pressure, lead us to take this as a priority goal if we want to work to advocate for the health of our population. Less than 14% of the population may be adequately treated and controlled, and this figure for Latin America shows also great disparity, but it may be higher. We may be closer to 25%, but at any rate, it shows a path, a significant path to follow, but this is a very simple guideline that establishes clear principles for treatment, and also the goal as how to get there, and also the options we have for treatment. And it also attempts to establish algorithms to get closer to the patients, and also to try to include this in such an important issue and such as implementation. This significant gap we have between knowledge and action, and how we can do so that our recommendations reach our patients. And in that regard, I think that this is also perfectly linked with the HEARTS program and implementation program, a project where all of the technical measures may change these recommendations into specific actions. We welcome both projects. We welcome the guideline, the dissemination, the communication of the guideline and also the development of this implementation program that is hard. A couple of days ago, we were talking about how we can cooperate from our own organizations, and I think that we have a lot to contribute. We have a lot to contribute because I think that we need to contribute collaboration, cooperation to try to focus on this from the same point of view. And I think that starting from that point of view, we have a lot to share from the scientific associations. So thank you all. Thanks again. And again, we offer our support to communicate this guideline, and let us continue communicating hard throughout our countries. Thank you. Kidney diseases are silent diseases that catastrophically affect our population. 1 out of 8 adults has this disease, which is also a mortality risk and also the second cause of years of life lost. And the treatment of extreme kidney disease, that is a lethal disease with dialysis and transplant, is also very high in prevalence in countries in the Americas, and more than 60 million individuals may have kidney disease in the Americas. Extreme chronic disease treated with dialysis and transplant affects a large number of patients in the Americas. The chronic disease is an increasingly prevalent disease in the Americas that is closely related to cardiovascular disease. Hypertension continues to be one of the main causes that are attributed to the kidney disease, and uncontrolled hypertension is also associated with a higher risk of cardiovascular death. And hypertension is a cause and an effect of the disease, and it affects mostly all patients. Control of hypertension is important among individuals that have chronic kidney disease, since it leads to a deceleration of progression of the disease as well as a reduction of the cardiovascular risk. Also, the hypertension control reduces the probability of having kidney disease. Hypertension control among kidney disease patients may also require a combination of hypertensive medicine as well as changes in lifestyle. A personalized, customized care control continues to be key to control blood pressure, to reduce cardiovascular risk, and also to reduce the prevalence of the disease, always based on evidence. The good news is that kidney programs in some Latin American countries that are also focused on the treatment and the control of hypertension, diabetes, among other diseases, have decreased the frequency of the disease, have also decreased the kidney replacement and also cardiovascular diseases that are linked to kidney problems in more than 20%. These measures may have a very significant impact on the population and also the use of the health resources. The Hearts Initiative, focused to diagnosing and also promptly treating hypertension and other determinants of chronic kidney disease such as diabetes, and offer a high impact scenario to diminish the development of chronic kidney disease, in particular cardiovascular disease. That's the reason why the Latin American Society of Nephrology and Hypertension commits to supporting this initiative and also fostering its expansion at the first level of care as a useful strategy to improve kidney and cardiovascular health of the population.
Hello, I am Sheila Martins. I am the president-elect of the World Stroke Organization. I'd like to congratulate the Pan American Heart Organization for launching the pharmacological guidelines for hypertension. Stroke is the second cause of death in the world. It is one of the main causes of disability. In Latin America, it is the main cause of death in many countries, with a huge economic and social impact. And what are the figures? There are 13 million new cases per year worldwide, 5.5 million deaths, out of which 87% occur in low and medium level of development countries. 1 of 4 of us will suffer stroke sometime in our lives. However, fortunately, 80 to 90% of cases could be prevented if we focus on 10 risk factors which can be changed. And the main cause, the main risk factor is hypertension, which represents 50% of risk attributable to stroke victims. So if we focus on hypertension, we will have a huge impact, not only in pharmacological treatments, but also by changing lifestyles. I'd like to congratulate the organization for successfully implementing the HEARTS program, as well as reorienting treatment at the primary healthcare level, focusing on blood pressure measurement, appropriate treatment, reaching goals, and monitoring patients, in addition to focusing in hypertension, also considering diabetes and dyslipidemia. I am sure that HEARTS initiative is the most powerful initiative we could have to reduce the impact of stroke in the world, and we support it and we'll be together in its implementation. I wish you success and thank you for this opportunity.
What else could we ask for? We have the presidents of 3 very influential organizations. I am going to give the floor to the last panel members that is supposed to close this session, and then we are going to give the floor again to the 3 presidents of the associations, in addition to Professor Nor Campbell, who is an emeritus scholar of the School of Medicine in Canada, and who will be sharing a very important message about policy making and also those who are in charge of implementing this type of programs. Please go ahead.
I'd like to thank you for the honor of being with you today on World Heart Day. This is a momentous occasion. Non-communicable diseases led by cardiovascular diseases are the leading cause of death in our region. And increased blood pressure is the leading risk for both death and cardiovascular disease in our region. The World Health Organization has recently released updated pharmacologic guidelines for the management of hypertension. It's up to policymakers now to take these guidelines and implement them to markedly improve the screening, diagnosis, treatment, and control of hypertension. We are very, very fortunate in our region to have the Pan American Health Organization provide a platform for implementing these guidelines regionally. The Hearts in the Americas program has been very, very successful in many countries, but needs to spread and scale to all the countries and to all of the populations. The Pan American Health Organization has a work group which is looking at policies which will aid your countries implement the WHO guidelines. We hope to have these released shortly. Again, I thank you for the honor of being with you today on this very important day for our region. Thank you.
Muy buenas. Este último segmento fue breve.
The last segment was brief, but it was a segment where we heard the support of the region for this initiative. I am going to invite all of the panel members to turn on the cameras. We are here on the final stretch of this session. And certainly, I invite all of the panelists, including the panelists from the first and second blocks, to join us, and also Professor Campbell, who closed the seminar magnificently. And I have here before me, Alejandro Ferreiro. Alejandro, is it the time then to work with nephrologists intensely and work on treatment to reduce cardiovascular risk rather than only focus on a topic? That is to say, to move forward with the treatment of hypertension that has so many advantages, as you mentioned, it would be a good idea. I have known Alejandro for a while. He has been working in a fantastic manner on COVID, and also he has been very vocal regarding the treatment of chronic patients and patients with chronic kidney disease, which is a risk group for COVID. It would be great to have an alliance, a partnership with our organizations that include cardiologists, nephrologists, so that we can all work together on the implementation of HEART. I give you the floor, HEART. Alejandro, what do you think? I totally agree, because in the case of the chronic kidney disease, hypertension is part of the kidney disease. It's not a risk element. It has an impact on a large number of the population, and as the kidney problem increases, the rate of cardiovascular disease also increases. But I also think that the HEART initiative is very interesting because it focuses on the first level of care doctor as the implementer of the program, and also the non-medical staff. I completely agree with what our colleague said at the outset, because if we think of nephrologists, we have about 20 nephrologists per million of the population. It is clear that the determinants of health for the control of chronic kidney disease is devastating in our countries, and clearly the use of these strategies is quite simple for diagnosis, for control, with low-cost medicines that have a high impact. And to conclude, I think that nephrologists should also meet, because we need strategies at the level of the population, and sometimes they lose sight of the specific subgroup of management. For example, those patients that have proteinuria chronic kidney disease that may need an adjustment in terms of blood pressure control, but this is in the hands of the diagnosing doctor or the professionals that are controlling the patient with a high impact approach. Thank you, and I have no doubts that we should all work together. Professor Campbell, I go over to you. When you started to promote HEART, it was not even called HEART back then. That was in 2013. These are the individuals that started to participate in the meetings, and we first started with Barbados. We started with Barbados, and then we added a few countries, but now we have almost 20 countries that are part of the initiative. You communicated a message to those who are implementing HEART, and what would you say to those who are still not implementing HEART, Dr. Campbell?
The governments in the region really have a responsibility for the health of their populations. Within the Americas, and including the countries that are not implementing, the leading risk for death and disability is increased blood pressure. In contrast to our response to COVID, hypertension has very, very strong evidence that its implementation will reduce death and disability. We also know that it's really cost effective, and hence it has to be one of the top priorities of governments within this region, as well as the rest of the world, to improve the health of their populations. And I really think it is up to the non-governmental organizations to advocate to the governmental organizations, and for the governmental organizations to really start to use the science that is out there to prioritize what they're going to do to prevent death and disability. And within this region, I think the governments are really fortunate to have HEART in the Americas, which is really, I won't call it a plug and play, it's much more complex than that, but at least it has the wherewithal that they can start and spread and scale to improve health in their populations. guessing.
Muchísimas gracias, profesor Campbell.
Thank you very much, Professor Campbell. Unfortunately, we ran out of time. And now I would like to communicate some messages first. This session is recorded. We have had a very large number of participants in the Zoom room as well as on the YouTube channel. This conversation is recorded, and once again, take it to the schools of medicine, discuss it with your students, discuss it also at the level of the primary care. This has been a webinar with excellent participation. Please check the support that we have by the nephrology, cardiology associations, as well as the stroke organizations. And I imagine that we will continue to have the support of other organizations. And another message that I would like to share with you, the next webinar will be on November 5th. We will be focusing on something that is closely related to this, the main drivers, the main determinants of the improvement in blood pressure control. How do we do it at the clinical level? And this is something that we will address in the next webinar. Finally, I would like to ask all of our colleagues and everyone who has participated. We also have the administrative staff and the company that works on the communication. We have our interpreters who have been great at trying to capture all of the details. I'm going to ask you to turn on your cameras, and we're going to you would recall that we included the cardiovascular risk calculator, but it was in Spanish. But then for those who work in English, they might be wondering, where is it? Well, now we're going to show it. You need to remember that first, we measure blood pressure. Second, we estimate the risk for cardiovascular disease, and also the calculator includes the logarithm for your country, but without any complication, without having to read 50 pages to understand what type of treatment it is. It is a simple treatment protocol with a few stages, few steps, and specific treatment, as Andrew referred to in his presentation. So to all, I would like to say goodbye, and music to conclude here on Friday. I wish you all good Friday and good weekend. Thank you all for participating. See you soon, and thank you. And we're going to have the family picture. We always have a family picture for hearts collection. So let's see, Jenny, and we will be sharing this with you. And Kenneth Connell is always asking me if there is Wi-Fi. Yes, we do have Wi-Fi, and we are going to share this with all of you. Professor Tipetti, Andrew, thank you all. Alejandro, Ken, Vilma, thank you all.
Thank you.
We also have Jenny and Cynthia, who are in charge of production. Jenny Rodriguez is in charge of production. Thank you all. And now we are going to play some music and look at the cardiovascular risk calculator that was being used today by more than 30,000 individuals. And we need to we know that we would like to have it used by 2 million individuals. So we are going to close now.